So today we will study about stomach, and first of all we would study the normal structure of the stomach. The stomach is a gland with cavity extending from its junction with the lower end of the esophagus to its junction with the duodenum, which is known as pylorus. The prior end is known as the cardia. The lesser curvature is inner concavity on the right, while the greater curvature is the outer convexity on the left side of the stomach. And the stomach has five anatomical regions. First of all, there's cardia, which is the esophagogastric junction and lacks the sphincter. Second is the fundus. It is a portion above the horizontal line drawn across the esophagogastric junction. Third is the body in the middle portion of the stomach between the fundus and the pyloric antrum. Fourth one is the pyloric antrum, and which is the distal third of the stomach. And fifth is the pylorus, which is the junction of distal end of the stomach with the duodenum. This powerful sphincter muscle. The mucosal folds in the region of the body and fundus are loose, which are also known as ruggy, while the antral mucosa is somewhat flattened. So gastric canal, it is the relatively fixed portion of the pyloric antrum and the adjoining lesser curvature. It is a site for numerous pathological changes such as gastritis, peptic ulcer, and gastric carcinoma. The stomach receives its blood supply from the left gastric artery and the branches of the hepatic and splenic arteries with widespread anastomosis. Numerous numerous gastric lymphatics which communicate freely with each other are also present. The innervation of the stomach is by the vagi and branches of the sympathetic, which are connected with ganglia in the muscular and submuscular layers. So here we can see the anatomy of the stomach. This is the cardia, fundus, body of the stomach, pyloric antrum, and this is the pylorus. Here we can see the cardiac mucosa in histopathology, and in body and fundus mucosa we can see the parietal or they are also known as oxyntic cells, then chief cells, endocrine cells, and in pyloric mucosa we can see the mucous cells and long tubular uh, glands. Now, histologically, we can see the wall of the stomach consists of four layers: the serosa, muscularis, submucosa, and mucosa. The serosa, which is the outer layer, is derived from the peritoneum, which is deficient in the region of lesser and greater curvatures. Muscularis consists of three layers of smooth muscle fibers: the outer longitudinal, the middle circular, and the inner oblique. Now, plexuses and ganglion cells are present between the longitudinal and circular layers of the muscle. The pyloric sphincter is thickened circular muscle layer at the gastroduodenal junction. Submucosa, it is a layer of loose fiber-connective tissue binding the mucosa to the muscularis loosely and contains branches of blood vessels, lymphatics, and nerve plexuses and ganglion cells. Mucosa, which again consists of two layers, superficial and deep. Between the two layers is the lamina propria, composed of network of fibrocollagen tissue with a few lymphocytes, plasma cells, macrophages, and eosinophils. The mucosa is externally bounded by muscularis mucosae. Now the superficial layer, we can see it consists of a single layer of surface epithelium composed of regular, mucin secreting tall columnar cells with basal nuclei. There is a rapid turnover of these cells. These dip down at places to form crypts, which are also known as pits or proteoli. First is the cardiac mucosa. It is a transition zone between the esophageal squamous mucosa and the oxyntic mucosa of the fundus and body, with which it gradually merges. Second is the oxyntic mucosa, which lines both gastric fundus and body. C is the antral mucosa, which lines the pyloric antrum. Now the deep layer consists of glands that open into the bottom of the crypts depending upon the structure. These glands are of three types: glands of the cardia, which are simple tubular or compound tubular vessels lined by mucin secreting cells; glands of the body fundus, which are long tubular and tightly packed, which may be point or dilated. There are four types of cells present in the glands of body fundus and mucosa. Parietal or oxyntic cells, these are the most numerous and line the superficial upper part of the glands. Parietal cells are triangular in shape, have dark staining nuclei, and eosinophilic cytoplasm. These cells are responsible for uh, okay. So now we see the parietal or the oxyntic cells. These are the most numerous and line the superficial or upper part of the glands. Parietal cells are triangular in shape, have dark staining nuclei and eosinophilic cytoplasm. These cells are responsible for the production of HCl, which is the acid of the gastric juice, and the blood group substances. Chief or peptic cells are the dominant cells in the deeper lower parts of the glands. Their basal nuclei are large with prominent nucleoli, and the cytoplasm is coarsely granular and vesicular. These cells secrete pepsin of the gastric juice. Then the mucin secreting neck cells, which are small and fewer. These cells are present in the region of the narrow neck of the gastric glands, that is at the junction of the glands of the pets. Fourth type of cells are endocrine, which are also known as Pulchishki or enterochromatin cells. So these are widely distributed in the mucosa of all parts of the alimentary tract and are described later. Glands of the pylorus are much longer than the body funding glands. These are simple tubular glands which are often coiled. Now the gastrin producing G cells which are present predominantly in the region of entropyloric mucosa with a small number of these cells in the crypts and tumors glands of the proximal duodenum. Secretory products of the gastric mucosa are the gastric juice and the intrinsic factor required for absorption of vitamin B12. Gastric juice consists of HCl, pepsin, mucin, and electrolytes. HCl, which is produced by the parietal oxygenatic cells and by the interaction of chloride ions of the arterial blood with water and carbon dioxide. The degree of gastric activity is correlated with the total parietal cell mass. Physiologically, the gastric secretions are stimulated by the food itself. The control of gastric secretions uh, is chiefly occurs in one of the following three ways. First is the cephalic phase, which is stimulated by the sight, smell, taste, or even thought of food. A neural reflex is initiated by branches of the vagus nerve that promotes the release of HCl, pepsinogen, and mucus. Gastric phase, which is triggered by the mechanical and chemical stimuli. Mechanical stimulation that comes from stretching of the wall of the stomach and conveying neural messages to the medulla for gastric secretion. Second is chemical stimulation. It is digested by proteins. Sorry, it is by digested proteins, amino acids, bile salts, and alcohol, which act on gastrin, producing G cells. Gastrin then passes into the bloodstream and on return to the stomach promotes the release of gastric juice. Intestinal phase, it is triggered by the entry of protein-rich food in the small intestine. An intestinal hormone capable of stimulating gastric secretion is probably released into the bloodstream. Now we come to the tumors of the stomach. So, first of all, we read about the pyloric stenosis. Now, what is pyloric stenosis? Uh, this is the hypertrophy and narrowing of the pyloric lumen, which occurs predominantly in male children as a congenital defect. It is known as infantile pyloric stenosis. The adult form is rarely seen either as a result of late manifestation of mild congenital anomaly or may be acquired type due to inflammatory fibrosis or invasion by tumors. Etiology, the exact cause of congenital or infantile pyloric stenosis is not known. It appears to have familial clustering and recessive genetic origin. The acquired pyloric stenosis is related to enteral gastritis and tumors in the region. Morphological features include dorsally, there is hypertrophy and hypoplasia of the circular layer of muscularis in the pyloric sphincter, accompanied by a mild degree of fibrosis. So here we can see this is the hypertrophy of the muscles and the lumen has narrowed down. So this is the pyloric stenosis, which is infantile type, and this is a longitudinal and this one is a transverse section of the stomach, which shows hypertrophy of the circular layer of muscularis in the pyloric sphincter. Other acquired conditions are bezoars. Bezoars are foreign bodies in the stomach, usually in patients with mental illness who chew these substances. Some of the common bezoars are as follows: trichobezoars composed of a ball of hair, phytobezoars composed of vegetable fibers, seeds of fruit skin, trichophytobezoars combine both hair and vegetable matter. Acute dilatation, sudden and enormous dilatation of the stomach by gas or fluids due to paralysis of the gastric musculature may occur after abdominal operations, generalized peritonitis, and in pyloric stenosis. Now we come to the peptic ulcers. So peptic ulcers are the areas of degeneration and necrosis of GI mucosa exposed to acid peptic secretions. They occur most commonly in either the duodenum or the stomach in the ratio of first to one. Each of the two main types may be acute or chronic. Acute peptic stress ulcers, acute peptic or stress ulcers are multiple small mucosal erosions seen most commonly in the stomach, but occasionally involved in the duodenum. Etiology. These ulcers occur following severe stress. The causes are as follows: psychological, physiological stress, lightning shock, severe trauma, septicemia, and morphological features. Grossly, the acute stress ulcers are multiple, more than three ulcers in 75% of cases. They are more common anywhere in the stomach, followed in decreasing frequency by appearance in the first part of the duodenum. They may be oval or circular in shape, usually less than 1 centimeter in size. Microscopically, the stress ulcers are shallow and do not invade the muscular layer. The margins and base may show some inflammatory reaction depending upon the duration of the ulcers. These ulcers commonly heal by completely epithelialization without leaving any scars. Now we come to the chronic peptic ulcers, which are also known as the gastric and duodenal ulcers. If not specified, chronic peptic ulcers will be the gastric and duodenal ulcers, the two major forms of peptic ulcer disease in the GI, in which the acid pepsin secretions are implicated in the pathogenesis. Peptic ulcers are common in the present-day life of the industrialized and civilized world. Gastric and duodenal ulcers represent two distinct diseases as far as their etiology, pathogenesis, and clinical features are concerned. So when we talk about the incidence, peptic ulcers are more frequent in middle-aged adults. The peak incidence of duodenal ulcer is fifth decade, while for gastric ulcer it is a decade later, that is sixth decade. Duodenal as well as gastric ulcers are most common in males than in females. Duodenal ulcer is almost 4 times more common than gastric ulcer. The overall incidence of gastric duodenal ulcers being approximately 10% of the male population. Etiology. The immediate cause of peptic ulcer disease is disturbance in normal protective mucosal barrier by acid pepsin resulting in digestion of the mucosa. However, in contrast to duodenal ulcers, the patient with gastric ulcer have low to normal gastric acid secretions, though true achlorhydrin response to stimulants never occurs in benign gastric ulcer. Besides, 10 to 20% patients with gastric ulcer may have coexisting duodenal ulcers as well. Thus, the etiology of peptic ulcers possibly may not be explained on the basis of a single factor, but is multifactorial actually. These factors are discussed as: first is the H. pylori gastritis, and NSAIDs induced injury are considered most important. So we will see all the etiological factors one by one. So H. pylori gastritis, about 15 to 20% cases infected with H. pylori and Anderson develop duodenal ulcer in their lifetime, while gastric colonization by H. pylori never develops ulceration and remain asymptomatic. H. pylori can be identified in mucosal samples by histologic examination, culture, and serology. Second is NSAIDs-induced mucosal injury. NSAIDs are most commonly used medication in the developed countries and are responsible for direct toxicity, endothelial damage, and epithelial injury to both gastric as well as duodenal mucosa. Third one is acid pepsin secretions. There is conclusive evidence that some level of acid pepsin secretion is essential for the development of duodenal as well as gastric ulcer. Gastritis. Some degree of gastritis is always present in the region of gastric ulcer, but it is never clear whether it is the cause of the ulcer. Other local irritants like heavily spiced foods, alcohol, cigarette smoking, unbuffered aspirin, etc. Dietary factors, nutritional deficiency have been regarded as etiological factors in peptic ulcer, that is, evidence of gastric ulcer. In poor socioeconomic strata, higher incidence of duodenal ulcer in parts of South India. So, however, malnutrition does not appear to have any positive role in peptic ulceration in European countries and the US. Psychological factors include stress, anxiety, fatigue, and ulcer type personality, which may exacerbate as well as predisposed to peptic ulcer disease. Eight is genetic factors. People with blood group O appear to be more prone to develop peptic ulcers than those with other blood groups. Genetic influences appear to have greater role in duodenal ulcers, as evidenced by their occurrence in families known as zygotic twins and association with HLA-G5 antigen. So here We can see the comparison between the duodenal ulcer and the gastric ulcer. If we see the incidence of duodenal ulcer is 4 times more than the gastric ulcer. Usual age of presentation is 25 to 50 years. Here we can see the age of presentation is beyond 6 decades. And this is more common in although both of them are more common in males, but here the ratio is 4:1 and here the ratio is 3.5:1. In etiological factors, we have already seen the H. pylori infection, and other factors may be hypersecretion of acid fats in association with alcoholic cirrhosis, tobacco, hyperparathyroidism, chronic pancreatitis, hereditary and genetic factors. Whereas in gastric ulcer, we can see gastric colonization with H. pylori. It may be asymptomatic as well, but there are higher chances of development of duodenal ulcer by this. And disruption of mucus barrier, most important factor, association with gastritis, bile reflux, drug liver, tobacco, etc. We see the pathogenesis of duodenal ulcer. There is mucosal digestion from hyperacidity, most important factor, it is, and protective gastric mucus barrier may be damaged. In pathological changes, this is most common in the first part of duodenum, and is often solitary, 1 to 2.5 centimeters in size, round to oval, and is punched out. And this is even grossly similar to duodenal ulcer. Okay, but this occurs most commonly along the lesser curvature and pyloric angle. Histologically, if we see, it is the duodenal ulcer is composed of 4 layers: necrotic, superficial exudative, granulation, and cicatrization. And it is almost the same, the gastric ulcer is almost histologically same as the duodenal ulcer. The complications may be hemorrhage, perforation here, and clinical features is pain, food relief pattern, whereas it in gastric ulcer, it is the food pain pattern. Okay. So night pain is common here. Melena is more common than hematemesis, whereas in gastric ulcer, hematemesis is more common. So in duodenum, melena is more common. Deep tenderness in the right hypochondrium. There is deep tenderness in the midline and epigastrium and gastric ulcer. So now we come to the, we have already covered the etiological factors and all. Now here we can see benign chronic peptic ulcer. This is a picture of peptic ulcer. This is also partial gastric. This is actually partial gastric specimen, showing a punch down round to oval ulcer on the mucosa, about 1 centimeter in size and penetrating deep into the vascularis layer. Now we come to the complications which can arise due to the ulcers, peptic ulcers. Acute and subacute peptic ulcers usually heal without leaving any visible scar. However, healing of chronic, larger and deeper ulcers may result in complications. The first complication can be obstruction, which is due to the development of fibrous scar or at or near the pylorus, results in pylorus stenosis. Healed duodenal ulcers cause duodenal stenosis. Healed gastric ulcers along the lesser curvatures may produce hourglass deformity due to fibrosis and contraction. Hemorrhage, minor bleeding by erosion of a small blood vessel in the base of an ulcer occurs in all the ulcers and can be detected by testing this tube or ocular blood. Chronic blood loss may result in iron deficiency anemia. Severe bleeding may cause ground vomitus or malaria. A penetrating chronic ulcer may erode the major artery and cause a massive and severe hematomesis and sometimes even death. Then there can be perforation, which is an emergency. Perforation occurs more commonly in chronic duodenal ulcers than chronic gastric ulcers. Following sequelae may result. On perforation, the contents escape into the lesser sac into the peritoneal cavity, causing acute peritonitis. Second, maybe air escapes from the stomach and lies between the liver and diaphragm, giving the characteristic radiological appearance of air under the diaphragm. Subclinic abscess between the liver and diaphragm may develop due to infection. Perforation may extend to involve the adjacent organs, that is the liver and the pancreas. Malignant transformation. The rectum cancers ulcerate, but ulcers rarely cancerate holds true for most peptic ulcers. A chronic duodenal ulcer never turns malignant, while less than 1% of chronic gastric ulcers may transform into carcinoma. Okay. So the clinical features, peptic ulcers are remitting and relapsing lesions. Their chronic and recurrent behavior is summed up by saying once a peptic ulcer patient, always a peptic ulcer patient. Two major forms of chronic peptic ulcers show variations in clinical features, which are as follows. First is the age. The peak incidence of duodenal ulcer is in per decade, while that for gastric ulcer is a decade later. People at risk, duodenal ulcer occurs more commonly in people faced with more stress and strain of life and periodicity. The attacks in gastric ulcers last from 2 to 6 weeks with interval of healing for 1 to 6 months. These factors we have already discussed. So, yeah, morphologic features grossly, if we see the gastric ulcers are found predominantly along the lesser curvature in the region of pyloric antrum, more commonly on the posterior than the anterior wall. Most duodenal ulcers are found in the first part of the duodenum, usually immediate post pyloric, more commonly on the anterior than the posterior wall. Typical peptic ulcers, if you see the peptic ulcers on here, so typical peptic ulcers are commonly solitary, small, round to oval, and characteristically punched down. Benign ulcers usually have flat margins and level with the surrounding mucosa. The mucosal folds converge towards the ulcer. The ulcers may vary in depth from being superficial to deep ulcers. So here we can see this is the benign chronic gastric ulcer contrasted with malignant gastric ulcer. This is benign because there's punched out margin, right? Punched out. And it is also small in size, whereas in malignancy, it turns larger in size and the margins are rolled down. Okay. Peptic ulcer and microcystic is shown. So, yeah, microscopically, chronic peptic ulcers have four histological zones from within outside. These are necrotic zone, which lies in the floor of the ulcer and is composed of membranous exudate containing necrotic debris. Then there is superficial exudative zone lies underneath the necrotic zone. The tissue elements here show coagulative necrosis, giving eosinophilic smudging elements with nuclear. Third is granulation tissue zone, which is seen merging into the necrotic zone. It is composed of non-specific inflammatory conflict. Fourth one is the zone of cicatrization, which is seen merging into a thick layer of granulation tissue. It is composed of dense fibrocollagen scar tissue over which granulation tissue rests. So here we can see these four layers that we have discussed so far. This is the tissue granulation tissue zone. This is the ulcerated mucosa. This is necrotic zone. This is superficial exudative zone, and this is the zone of cicatrization. So this is the diagram of the chronic peptic ulcer. Now we come to the gastritis. The term gastritis is commonly employed for any clinical condition with upper abdominal discomfort like indigestion or dyspepsia, in which the specific clinical signs and radiological abnormalities are absent. Broadly speaking, gastritis may be of two types, acute and chronic. Acute gastritis is a transient acute inflammatory involvement of the stomach, mainly mucosa, and the etiological factors can be diet and personal habits, which includes highly spiced food, excessive alcohol consumption, malnutrition, heavy smoking. The infections, if there can be H. pylori, diphtheria, salmonellosis, viral infections like hepatitis, influenza, etc. Drugs, the intake of drugs like NSAIDs, aspirin, cortisone, phenylbutazone, medicine can be there. Chemical and physical agents like intake of corrosive chemicals such as caustic soda, phenol, Lysol, gastric radiation, severe stress factors like shock, anger, resentment, burns, trauma, surgery. In acute gastritis, the mucosal injury by any of the above agents causes acute inflammation by any of the following mechanisms like reduced blood flow, decreased acid secretion, or maybe decreased production of bicarbonate buffer. Grossly, the gastric mucosa is edematous with abundant mucus and mucus discharge. Microscopically, depending upon the stage, there is a minimal amount of inflammation that mucosa lamina propria. acute hemorrhagic and erosive gastritis. The mucosa is slowed off and there are hemorrhages on the surface. So this is the classification of gastritis. In acute gastritis, the factors can be expanded by gastritis, other acute infectious gastritis like bacteria, viruses, fungi. Chronic gastritis can be type A, type B, type AB, chemical miscellaneous forms of gastritis. Okay. And now we study about the chronic gastritis. Chronic gastritis is a complex histological change observed in biopsies from the stomach. This condition occurs more frequently when advanced in age. Average age for symptomatic chronic gastritis being 45 years, which corresponds to the age incidence. Pathogenesis. In absence of clear etiology of chronic gastritis, a number of etiological factors have been implicated. Like recurrent attacks of acute gastritis may result in chronic gastritis. Some additional causes are some reflux of duodenal contents, infection with H. pylori, associated disease of the stomach and bowel, chronic hypochondria, and immunological factors such as autoantibodies to gastroenteritis as in atrophic gastritis. So classification type A gastritis, or which is also known as autoimmune gastritis, which involves mainly the body funded mucosa. It is also called as autoimmune gastritis due to the presence of circulating antibodies and is sometimes associated with other autoimmune diseases such as Hashimoto's thyroiditis and Addison's disease. It is due to depletion of gastric acid producing mucosal area. There is hypo or achlorhydria and hyperplasia of gastrin producing T cells in hyper resulting in hypergastrimia. And here is a result of the antibodies against parietal cells and intrinsic factor. There is depletion of parietal cells and impaired secretion of intrinsic factor. Type B gastritis, which is also known as H. pylori related. So it mainly involves the region of antral mucosa and the small tongue, which is also called as respiratory gastritis, reflects as a secretion present of acute infection with H. pylori. Third type is type AB gastritis, which affects the mucosal region of A as well as B type. This is the most common type of gastritis in knowledge. Also called as environmental gastritis because a number of unidentified environmental factors have been implicated in its etiopathogenesis. So here we can see, we can compare the mucosa. This is the normal pyramid mucosa, and here in chronic atrophic gastritis, we can compare there are the goblet cells. So there is marked gastric atrophy with disappearance of gastric glands and appearance of goblet cells. So instead of normal gastric glands, there is appearance of goblet cells, which indicates intestinal metaplasia. And B1 is a photomicrograph showing chronic atrophic gastritis with intestinal metaplasia. This is the histological appearance of H. pylori chronic gastritis, and this is a genuine stain and demonstration of H. pylori in genocide. There is chronic inflammation as well. So consequences of long-term H. pylori gastritis can be when H. pylori infection is there after months, it can convert into chronic condition, which may be asymptomatic at all, or it may turn to antral or atrophic gastritis and non-atrophic pan-gastritis. When it comes to antral gastritis, there is duodenal gastric ulcer like 3 to 6 times more common. In atrophic gastritis, there is intestinal metaplasia or dysplasia, which can lead to gastrocarcinoma. In non-atrophic pan-gastritis, it can lead to lymphoproliferative disorders like Malt lymphoma. And the morphological features, if we talk about grossly, the features of all forms of gastritis are inconclusive. Gastric mucosa may be normal, atrophied, or edematous. Histologically, there can be categorization based on the following: extent of inflammatory changes in mucosa, activity of inflammation, and presence and type of metaplasia. So, based on above, the following simple morphological classification has been proposed for gastritis: chronic superficial, chronic atrophic, gastric atrophy, chronic hypertrophic, which is also known as Mentrieri's disease, and uncommon forms of chronic gastritis. So this is the Sydney system of recording of histological changes in gastritis. This is more common. And now we will start with the chronic superficial gastritis. As the name suggests, there is an inflammatory infiltrate consisting of plasma cells and lymphocytes in the superficial layer of the gastric mucosa. but there are no histological changes in the tail pair of mucosa containing gastric glands. It is most common uh, in the conditions where H. pylori infection is there. H. pylori plays an important role. Chronic superficial gastritis may resolve completely or even may progress to chronic uh, gastric atrophy. It is not seen on areas with intestinal metaplasia. H. pylori gastritis can be diagnosed by the following techniques: invasive techniques like endoscopic biopsy or histologic examination combined with special stains, DIMSA, steamer symbol, or Walton study, biopsy, reveals tests, and the culture of the microorganism. Non-invasive tests like serologic tests, which may include immunoblot, ELISA, potency, urea, breath test.